Good morning, everybody. Good afternoon to everyone online. Thank you for joining us today on World Anemia Awareness Day. Before kicking off the webinar, I would like to start by sharing a few practical points. Next slide, please. We have some housekeeping points, which are always important. All participants' videos and microphones will be switched off during the webinar. This webinar will be recorded and the recording will be shared online on the Micronutrient Forum YouTube channel. We'll have an English and we hope also a French recording. Please ensure that you are logged in with your full name and affiliation so you're visible to others in the way you want. If you want to rename yourself, you can right-click on the three dots at the top right corner of your Zoom window. Please use the chat function at the bottom of your screen to introduce yourself and to write general comments. But if you want to ask questions to the panelists, to the speakers, please use the Q&A function, and we will try to respond during the webinar and in the Q&A at the last 15 minutes of this session. In case you have any technical difficulties, kindly send a direct message to tech support. We also will have simultaneous interpretation available in multiple languages. Next slide, please. We use AI translation using the application Worldly for this. So if you want translated captions in text, please look at your panel at the bottom of this screen, click on apps, select at the Worldly translation and captions. It's down at a line, alphabetical order. And you can select your preferred language in the drop-down menu and read the captions below. That's the easiest way. If you prefer to listen to translated audio, it's different. Click on the Worldly link that's being put in the chat now to open a new browser window, or the Worldly drop-down menu on the right top corner in Zoom and click on Worldly. It will open in a new browser window. There you can select your preferred language from the drop-down menu and you click on the audio icon to start the live audio translation. To avoid overlap, because you'll be hearing two voices then. To avoid overlap, you have to mute your Zoom application audio by clicking on the small arrow next to the audio button in the Zoom panel. And there you select leave audio or disconnect audio. That means that you will not hear the original language spoken, but the translated one. C'est très important pour les gens qui parlent français que vous utilisez cette traduction. Il y a une version française de ce que je dis aussi dans le chat. If you want to exit Wordly because it's back to the language you would like to use, close your browser tab to end Wordly audio translation. If you have used translated captions, you go to the Worldly Translation and Captions drop-down menu and select Return to My Apps or Close Current App. So those are all the housekeeping points. I would like to go to the next slide. And for those who are just joining us, the practical points that I've highlighted can also be found in the chat. I'd like to welcome you all to today's webinar, which is entitled Accelerating Progress Against Anemia, Multi-Sectoral Solutions for Success. This webinar is co-organized with the World Health Organization and the Micronutrient Forum on behalf of the Anemia Action Alliance. My name is Marty van Lieren and I'm a senior advisor to the Micronutrient Forum. And today is World Awareness Day. Despite decades of research and programmatic efforts, anemia still remains one of the more pressing global health challenges, specifically for women, adolescent girls, and children. Though the global health community knows what to do to prevent and treat anemia, there's still an urgent need that knowledge is put into different action, differently from what we have done so far. And the objective of this webinar are then also that we want to promote a comprehensive and coordinated approach to anemia reduction. We need to address all determinants and risk factors that lead to anemia. And we need to integrate interventions across multiple health areas. We also aim to learn from the successes and the challenges that the different organizations represented by our panelists and countries or regions have been encountering in their efforts to implement such a comprehensive anemia approach. And finally, we would like to speak to you about the Anemia Action Alliance and the work it is undertaking. So if we go to the next slide, you will see that we have a wonderful lineup of speakers and panelists. You can read through this yourself. I'm now only going to introduce the first speaker, and we will gradually introduce the others. It's really my pleasure to introduce to you Dr. Luz Maria de Regil, who is the director of the Department of Nutrition and Food Safety at WHO. Luz is an epidemiologist with over 20 years of experience, and she has been holding very senior roles in both WHO and also Nutrition International. Luz, I know you will frame this webinar with an emphasis on this comprehensive approach and the need for integration, but I know you'll give your own touch. It's great that you have been able to make time to be with us today, and the floor is now yours. And we can close the slides. Thank you.
Thank you so much, Marty, and I hope that you hear me well. It is my pleasure to welcome you all to this webinar celebrating the World Anemia Awareness Day. I was looking at the chat, and it's truly wonderful to see such a diverse group. I can see country colleagues, program leaders, researchers, representatives from governments, partners, all of us coming together with a shared purpose to really discuss and learn how we can do better for anemia. My thanks to, of course, the Anemia Action Alliance and the Micronutrient Forum for the invitation to share a couple of thoughts on how we can do better for women, for adolescents, for children, and for those whose health depends on a more integrated, more responsive systems than the ones that we have today. And we need to start from the recognition that we can do better, and it's feasible to integrate anemia interventions, anemia prevention interventions, or anemia management interventions into the different areas of healthcare. So I will just make 3 points to frame our conversation. The first is just to reiterate what Marty just said. Anemia is still one of the most widespread but least visible threats to women's and children's health. We often talk about women and we forget that anemia in children is highly, highly prevalent. We have been talking about it for years. And in some cases, what we are facing now is, and I see it in many countries, some lack of interest because it's not longer new. However, what I also see is that there is a strong recognition that there are solutions across multiple sectors, and it gives us a new way of seeing the problem about integration, about learning, about co-sharing responsibilities. Because the costs of anemia are not minor, and whoever has had anemia, they know it. It's about learning, it's about productivity, it's about well-being, and it's about pregnancy outcomes. It's about lives that if we don't act on them, they accumulate silently across generations and generation after generation. The second point that I would like to make is that many of you don't know, and we need to do better also in communicating this, is that the last year, the World Health Assembly not only extended the anemia target to 2030, but also adopted an operational target to accelerate anemia action in pregnant women. The target is about increasing the percentage of pregnant women consuming at least 90 doses of iron-containing supplements, and I'm reading it now so I don't make a mistake. So it's 90 supplements in pregnancy, which has proven to be the most effective course dose to prevent anemia in pregnancy. And we have to increase the coverage of this intervention from 35% that we have today to 55% in 2030. If we achieve this would be a great step forward. But we know that it's not easy, and that we know that we have to be more intentional about how we integrate this with maternal services and all the disease treatment services. And there are other two operational targets that are very relevant to this conversation, not related to health systems necessarily, but very relevant. We have two operational targets on minimum dietary diversity among children between 6 months and 23 months of age, and minimum dietary diversity among women. And why is this important? Because we know that if women and children don't have enough variety in their meals and in their diet, anemia is more likely to appear. But we also know that there is an intervention that can help, which is food fortification. It has consistently proven that when diets include some fortified foods, the prevalence of micronutrient deficiencies are lower. And the third point that I would like to make is that integration is not aspirational. It is happening in pockets already. And many of you are already demonstrating how we can link nutrition with malaria, neglected tropical diseases, antenatal care, education, and we can use also health and community delivery platforms. So I hope that this, and with the resources that we have with Anemia Action Alliance, we can take again that energy towards achieving the target that we have, that member state committed, but also to really make an impact in the lives of many women and children. As a personal thought, I will just share that I believe that anemia is a marker of gender inequity. It affects disproportionately women and girls. And as I was saying, the losses are not minor. It's about lost learning, lost earnings, higher maternal risks, and probably even opportunities in terms of employment and life in general. So I'm looking forward to learning from all of you. I wish you a wonderful webinar, but I think that what is more important is that the conversation continues. So we not only share what we have learned, but how we can continue learning together. And with that, I send back the microphone to you, Marty.
Thank you so much, Luz. And I know it is actually really difficult to keep up the momentum for anemia because of what you said. Everybody knows what anemia is, and there have been programs for such a long time. But we haven't solved the problem. And therefore, I think it is really important that we keep on banging the drum. And even though it may not be aspirational, I think we can learn from each other on how we can do better. And we should, I'm a nutritionist, you're a nutritionist. A lot of people on the call or on the webinar may be nutritionists, but I do hope that we are also touching people in other areas, because that is what is important. We need to go beyond nutrition. Iron supplementation, iron deficiency, iron supplementation, only one of the causes. But then what about the infections? What about all of the other points? And that is why I now would like to go to the next panel. And I would very much like to introduce the next panel and ask the panelists to open their cameras. Thank you very much, Luz, for this inspiration. Oh, the other thing I wanted to say on your talk was, the operational target that is there, at least the 90 tablets. And I know that you have also spoken to us about we need maybe other indicators, because we know what gets measured gets done. So maybe even if it's not in the SDGs, maybe with other areas, health areas, we should discuss and say, well, how can we maybe measure our collaboration and the integration? What can we do for that? And with that, I'd like to go to introduction of the first panel. I'd like to start with Ms. Gita Lau, who is a Senior Technical Advisor, Strategic Partnerships of UNFPA, the UN, used to be called Family Planning Agency. Gita has a very long-standing career in UNFPA, where she's currently the global coordinator of UNFPA's flagship midwifery program. She's also the lead manager of their global midwifery program in collaboration with the International Confederation of Midwives, as well as a partnership with Intel and JHPIGO on mHealth. The second panelist is Ms. Molly Anderson, director of the End Fund. And the End Fund is leading efforts to control and eliminate neglected tropical diseases. Lots of worm infestations worldwide. And Molly oversees strategic programs, builds global partnerships, and drives advocacy to improve health outcomes in the affected communities. And last but not least, I would like to introduce to you Professor Olubenga Mokuole, Professor of Pediatrics, Malaria and Neonatology in Nigeria. But he is here in his role as co-chair of the Rollback Malaria Partnership to End Malaria Case Management Working Group. And Dr. Olubenga is so kind to stand in for his colleague, Dr. Noela Umulisa, who is also co-chair of the same working group, but has unfortunately fallen ill and cannot be with us today. So why do we have these three people here? And can I have the slide number 6, please, Gurmeet? The Anemia Action Alliance has been working with these three organizations over the past couple of months to develop a couple of briefs highlighting the relationship between sexual reproductive health, neglected tropical diseases, and malaria and anemia. And these briefs are today not yet available to you. We are finishing their development and need to get approval from both UNICEF and WHO, but we hope that we will be able to disseminate them together with 2 other briefs that are still in an earlier stage of development in the next couple of months. So I wanted to mention that. Now, again, these briefs are not telling you what to do, but it's really to highlight and to make clear to our colleagues for use of people in countries, in regions, to start that discussion with colleagues that do nutrition, that work in malaria, that work in SRH, that work in neglected tropical diseases, so that we can say, how can we even work better together? Anyway, you can take the slide off, Gurmeet, and I'd like the panelists to open their cameras and start asking you the very first question. Geeta, the first question is for you. I do not see you, I think. Maybe that's my mistake, but I think Gurmeet, I see still that Luz is on the big screen. Anyway, maybe you can change that. So I would like to start with the first question, and I will ask it first to Geeta, then Molly, and then Professor Olubenga. The question really is about how does addressing anemia outcomes or anemia strengthen the specific outcomes that your organizations are setting priorities on? So Geeta, for you, that is sexual reproductive health outcomes, right? So how does working on anemia help the SRH outcomes? And I'll give you 4 to 5 minutes, and then we'll move on to Molly.
Thank you so much, Marty. I hope you can hear me. Excellent. So good morning, good afternoon, good evening, colleagues, and thank you so much to the organizers for inviting me to this World Anemia Awareness Day webinar. UNFP is deeply proud to be a partner of this Anemia Action Alliance, and it's not just because of its relevance to sexual reproductive health and rights, but also because anemia requires urgency, as was expressed by Marty and Dr. Luce prior to me. And there is a need to come together and consolidate our efforts. So just a very, very brief look at the global context. So, and it has already been mentioned that world is currently off track to meet the 2030 targets of reducing anemia in women of reproductive age by 50%. And this is not just a nutritional deficit or just a SRH issue. It is a profound manifestation of gender inequality. Women are 3 times more likely than men to be anemic. This disparity is driven by biological demands, menstruation, pregnancy, and lactation, which gets worsened by systemic barriers like unequal access to healthcare, education, and food security. Today, 31% of women of reproductive age and 36% of pregnant women globally are living with anemia. And when you look at these figures, these are not small numbers. And these link directly to the SRH outcomes that UNFPA has pledged to address. I just want to mention one more thing, that anemia is also a life course issue. And that has also been, and we all know about it, that it begins long before a woman enters the delivery room. It begins at the adolescent stage. Rapid growth and onset of menstruation in adolescents combined with poor access to nutrient-dense foods in low-middle-income countries creates an early deficit. And beyond nutrition, while iron deficiency accounts for 2/3 of cases, we also have to address obstetric conditions, infections, and inherited blood disorders. Addressing anemia is also a very, very cost-effective triple win in global health, particularly in sexual reproductive health and rights. It saves the mother, protects the child, and empowers the women to lead productive, healthy lives. If we ignore anemia, we ignore the foundations of sexual and reproductive health. So we need to aggressively and effectively address anemia. We don't just improve nutrition by addressing that. We transform some of the following reproductive health outcomes that, Marty, you have asked me about. First and foremost is about maternal and newborn survival and well-being. One of the leading causes of maternal mortality, as we know, is postpartum hemorrhage, and anemia is a leading indirect cause of maternal deaths. A woman with healthy hemoglobin levels can often survive standard blood loss during birth. A woman with severe anemia cannot. Secondly, severely anemic women face the double risk of death. Furthermore, they are likely to give birth to anemic children, compromising the child's cognitive development and motor skills from day one. So it also has an intergenerational impact, so coming back, linking it back to the life course approach. And adequate iron levels directly correlate to a reduction in preterm births, low birth weight, and stillbirths. So these are all huge issues, and we are also off target on these big issues. Second big thing as related to sexual and reproductive health is fertility and sexual well-being. So anemia can impair fertility and the body's ability to sustain a healthy pregnancy. Improving iron status restores a woman's autonomy of her reproductive choices and her ability to nurture a family. We don't talk about it often, but it also impacts vitality and libido. We often overlook the quality of life aspect. The chronic fatigue associated with anemia reduces libido and sexual function. Restoration of health enhances overall sexual well-being and relationship health, again, linked with sexual and reproductive health. And again, adolescent empowerment, I want to say just a few quick words about anemia and adolescent health, and particularly sexual and reproductive health. Because we know that around 15% pregnancies occur in adolescent years in low-middle income countries, with 95% occurring in low-middle income countries. And during pregnancy, with the blood volume expansion, iron demands skyrocket. And for the 21 million adolescent girls who become pregnant, these dual demands, their own growth and the growth of the fetus, creates a perfect storm for deficiency. So if we want to address anemia in adolescent girls, we improve, not just their reproductive health, but also their cognitive focus and school performance. Just in closing, I would just want to say a few words that if a woman is anemic, her choices are limited by fatigue and pregnancy shadowed by risk, and a child's future is compromised even before it begins. I'd like to just stop there. Thank you.
Thank you, Geeta. And this is very powerful. You bring in gender inequality. You talk about life course. You talk about vitality, actually, and full well-being. So I think very powerful statement from you. Molly, I'd like to go next to you. And the question is the same, but then with your focus on neglected tropical diseases, as the End Fund is doing that.
Thanks, Marty, and thanks for inviting me to present today. It's really a pleasure to be here. So my focus is on neglected tropical diseases and the relationship between anemia and NTDs, particularly intestinal worms and schistosomiasis, is really bidirectional. Addressing anemia strengthens NTD outcomes, and on the other side, addressing NTDs strengthens anemia outcomes. So NTDs do drive anemia, soil-transmitted helminths or intestinal worms, and schistosomiasis cause chronic blood loss and inflammation. Hookworm in particular creates ongoing intestinal bleeding, and schistosomiasis causes both blood loss and immune activation that reduces iron utilization. In these co-endemic settings, these infections stack, and anemia becomes an everyday expression of the cumulative NTD burden. The relationship does run the other way too, as anemia undermines NTD program effectiveness. When someone is iron depleted and anemic, deworming may clear the infection itself, but then they may still feel fatigued, weak, cognitively impaired, as Gita was mentioning, and the parasite is then gone, but recovery is incomplete and the body hasn't fully rebounded. We see a simple but powerful dynamic. Treating NTDs reduces anemia, and treating anemia strengthens NTD results. Deworming programs are particularly effective at reducing anemia in hookworm endemic settings, where chronic blood loss is a primary driver. But when deworming is paired with iron supplementation, we see stronger hemoglobin recovery, better growth outcomes, and more sustained health improvements than with either intervention alone. The overall burden makes this even more compelling. Again, school-age children, adolescent girls, pregnant women are the most at-risk populations for both anemia and NTDs. So once again, harping on this life cycle approach, it really creates a great integration opportunity. If we deworm adolescent girls, we protect iron stores before pregnancy and then strengthen those gains by addressing anemia during those critical years. Treating parasitic infections during pregnancy removes a major source of iron depletion, and managing anemia to reduce the maternal risk and improve newborn health outcomes. And then finally, deworming school-age children stops that ongoing iron loss and restores hemoglobin levels to unlock the gains in cognition, school performance, and again, overall well-being. So this really isn't a parallel agenda, it is a multiplier. The integration logic is straightforward. Deworming stops the drain, iron and folate rebuild the tank. Together, they produce meaningful improvements in energy, functioning, and well-being that neither intervention achieves alone. And this matters for the sustainability of both programs. If we deliver deworming treatment without addressing iron depletion, communities may see the infection rates drop, but still feel unwell. And people are going to judge the programs by whether they feel better. So integrated delivery, combining intestinal worm and schistosomiasis treatment with iron and folate supplementation, alongside your basic wash and environmental management, produces improvements that people actually experience in their everyday lives. It builds trust, that strengthens the uptake and adherence, and it makes reductions in morbidity more durable and long-lasting. From a global health perspective, this pushes us beyond single disease delivery toward integrated morbidity reduction. Addressing anemia brings NTDs, nutrition, maternal and school health, and WASH platforms into alignment around an outcome that ministries and communities genuinely care about. When we do that, we see a maximizing of the impact of both.
Mhm. Thank you so much. I mean, it's interesting. You also mentioned the life cycle, but I really, you were talking about the two-way impact, and you were talking about a more sustained health improvement and also feeling better. So really, what is the experience of the people? Thank you very much for this. Now, Professor Benga Mokuolu, very happy you're here. So for you, and please restrict your answer to 4 minutes so that we have also a second question. So how does anemia strengthen specific outcomes that are malaria related? How does addressing anemia and malaria together has that interactive effect? Over to you.
Yeah, so thank you very much, Mati, and thank you to all the participants on this webinar. From the RBM perspective, malaria and anemia are deeply interconnected. I think you can say they are Siamese twins, especially for women and children in endemic settings, because the parasite invasion directly destroys red cells. And so wherever you have malaria, anemia is actually the commonest complication that arises from malaria, either in terms of chronic anemia or in terms of severity leading to severe malaria. So when you address anemia, it reduces severity and mortality of malaria in the first instance. Just as I've said, because malaria destroys the red cells and suppresses bone marrow function, when we address anemia, it helps to improve this function, reduces life-threatening scenarios from occurring, and the risk of complication from severe disease. Secondly, addressing anemia improves the effectiveness of malaria interventions. Because anemia weakens immunity, it increases susceptibility to repeated malaria infection. So when anemia is prevented or treated alongside malaria intervention, such as in case management or in intermittent preventive therapy in pregnancy, we tend to have greater impact. So importantly, strong malaria prevention is essential to ensure that iron and nutrition interventions are delivered safely and effectively in endemic areas. The third point I would like to make is that addressing anemia strengthens maternal, newborn, and child health outcomes, which are central to malaria impact, because malaria-related anemia in pregnancy contributes to low birth weight, prematurity, stillbirths, and neonatal deaths. Thereby, reducing anemia improves outcome across malaria in pregnancy, newborn survival, and child uh, development. Finally, I'd like to say that from a health system and equity perspective, anemia disproportionately affects the poorest and most vulnerable populations. So addressing anemia through malaria platforms improves equity, maximizes the return on malaria investment, and strengthens integrated service delivery. Let me stop here and I'll take the second round of questions.
Thank you very much. And you also, a little bit like Molly, emphasize, I feel, that effectiveness of impact. It's almost, I should look into that, but it's almost as if we could, what decision makers are very interested in is how much how much bang do I get for my buck? But if we're addressing anemia together with these different conditions, looking at a person as a whole, not just as only anemia or only risk for malaria, etc., we may be much more we may have much more impact. So we do have time for a second question. I would like you to be a little bit shorter. You're doing really well, everybody, but a little bit shorter in the second question answer, because one of the things that Luz said is, integration is not necessarily aspirational because it's happening on the ground. Still, I think what we do see is we need to have more impact because anemia has not, the needle hasn't been really moving in the right direction. So maybe it's more in the how we do it. We know what to do, but how do we do it? So my question to all of you is, what lessons have you learned, either in a success or a challenge, about the integration of, let's say, really particular SRH, malaria or NTD interventions with other interventions such as indeed nutrition interventions. But what successes or challenges, and please stick to 3 minutes maximum, have you learned from integration so that we can start doing better in the how we address? And the first person I'm asking to answer the question will be Molly. Second will be Professor Benga, and then the third will be Gita. Molly, over to you for that second question.
Thanks, Marty. The core lesson that we've learned is that, like you said, integration works, but it takes intentionality. It really requires a deliberate cross-sector coordination and the right delivery platforms. Our work in Ethiopia offers a really strong example of what's possible by embedding deworming into the nutrition platform through partnerships between the Federal Ministry of Health and UNICEF. Over 75% of pregnant women and preschool-age children in intervention areas are now receiving deworming through this routine nutrition services. And through policy change and advocacy, young children 12 to 24 months are now eligible to receive deworming treatment. But the real success isn't just that coverage. Again, it is integration. Deworming of these key populations embedded into the routine services, not delivered as a standalone campaign. We know that the biological logic is clear. NTDs contribute to malnutrition, and malnutrition limits recovery from NTD infections. But when deworming is paired with iron or micronutrient supplementation, we see stronger hemoglobin recovery and better growth outcomes than with either alone. There's also, as you mentioned, Marty, a really compelling economic case. A 2022 analysis estimated that eliminating NTDs in Nigeria could generate nearly $19 billion in productivity gains, with soil-transmitted helminths and schistosomiasis driving the largest share. When you consider the global cost of inaction for anemia, the economic opportunity of integration is enormous. But we know that integration doesn't happen automatically. The vertical program structures are a major barrier. NTDs and nutrition programs often sit in separate departments within different budgets and planning cycles. Integration also requires the alignment of procurement and distribution systems that were built to operate independently. And most monitoring systems still track single interventions, not integrated outcomes. Where integration works best is through strong platforms. In schools where we combine deworming with weekly iron folic acid supplementation, through antenatal care, linking deworming in pregnancy with iron supplementation and screening, and community health platforms where we're reaching high-risk populations through integrated delivery. So the bottom line is integration produces better health, stronger program performance, and greater economic return, but it requires intentional cross-sector architecture, not just opportunistic co-delivery.
Thank you. And I do think it's important that though the economic argument is always a big push, I think, if we have for the decision makers, we should not forget the fact that this is also about a human-centered approach. The people, it's better for them. They feel better. They are treated. Every condition is being addressed, and then that assistance need to be strengthened. Professor, can I ask you the same question for malaria? So can you mention one success or challenge, something you've learned about integration, malaria interventions, and other anemia reducing interventions?
Yeah, so one major area of success is the what we call the RMNCH integration. That's the reproductive, maternal, newborn care, plus nutrition and anemia care in the area of antenatal care and child health services. These are two important platforms where you deal with anemia as well as deal with malaria, and it gives you a one-stop solution in being able to use that platform. The main challenge, though, is that anemia is multi-causal agents from genetic factors to infectious diseases, whereas, malaria is a parasitic infection. So we cannot say that one size fits all in addressing every single concern of anemia. However, considering the contribution of malaria to anemia, the platform that addresses both significantly addresses the burden of anemia concurrently. So strong malaria prevention and case management are essential, especially when delivering iron intervention to the patients. Now, the other challenges sometimes are health system constraints, such as the workforce capacity, the diagnostics. It's not just sufficient to know the hemoglobin level, but you want to know the characteristics so that you can respond more comprehensively. And then, of course, there are financing issues. It works both ways. It can be cost saving, and then it can sometimes also increase your cost limits. Overall, the key lesson that I would say from the RBM perspective that we have learned is that country-led, coordinated, and data-driven integration strengthens equity, efficiency, and impact around both malaria and anemia. And when malaria programs are designed to support the broader anemia reduction, we achieve better outcomes for mother, children, and communities.
Thank you very much. And really important what you were saying. Not every context is the same. Anemia has multiple causes and it really depends on the context. And one point we're not addressing in this webinar, but that's being addressed, has been addressed previously and elsewhere, is that data-driven approach. So it's really important to do an assessment of what are the anemia drivers in the context that you live or work, to see how can we work in that. And the other point you mentioned, country-led, and really looking at the systems and the delivery platforms that are there. Geeta, I'm coming to you now. The same question on a success or a challenge for integrating other anemia interventions with sexual reproductive health interventions.
Thank you so much, Marty. Actually, my fellow panelists have really alluded to several examples that, that how important it is to link anemia to, say, menstrual health, maternal newborn health programs, children programs, NTDs, and malaria programs. So, just to mention a few. And there's strong global efforts underway currently, to really integrate RM and CAH programs as well, and which are showing results. But I agree with Molly that intentionality thing is still missing, So I appreciate the work of the Alliance to try and bring partners together. So there is still a lot to be done. It's happening, but it's happening at a much slower pace than it should be. So really, integration is at the key to most of all our efforts. And two additional things I would like to mention. One is of course about antenatal care. It's been mentioned, but not strongly enough, because that's the primary entry point. So by adhering to the WHO recommendations, for instance, of 8 ANC visits and combining it with a bundle of life-saving services, screenings, nutrition counseling, IFA micronutrient supplementation, malaria, IPTP, and deworming, for instance, in endemic regions, and delayed cord clamping, these can also be very effective in treating anemia. And countries where this is happening, we are seeing results like the Philippines, Bangladesh, and many, many others. The second one is, of course, training of healthcare providers. So I lead this global program on midwives, and we are seeing that midwives and community health workers, who are the most trusted figures in communities, by training them additionally as nutrition counselors, not just as birth attendants only, we extend the reach of anemia care to the last mile. And in Nigeria, Ethiopia, bundle of a lot of these services are being bundled, and but there are supply chain issues. There are issues. Again, Molly alluded to that, but I personally see that a big issue is about this vertical funding and siloed departments. I think the donor-driven also, and I would even say that we as UN need to come together, together with all the partners, because vertical funding is a huge issue. The donors give fund for their mandates, for their issues, for specific projects, and it becomes really difficult to integrate, say, malaria programs with reproductive health programs, because I'm constantly, for instance, I'll give you my own personal example. I'm constantly justifying how midwives should be integrated, midwifery training should be integrated into also this malaria elimination programs, etc., for which funding, or HIV/AIDS programs, etc. So this integration issue, supply chain issues, and there are socio-cultural barriers also that we need to simultaneously target. That, and most importantly, that it is a issue that requires extreme urgency and collective efforts. Thank you.
Thank you so much, Geeta. And thank you so much to also the other panelists. I think it's really exciting to talk about this from multiple angles, to bring people together. I found it exciting to work on those briefs over the past month. And what I hear, the integration takes intentionality. And actually, these programs that we have set up over the past decades, the vertical programs, they've done a lot of good in specific areas and driven targeted agendas. But now we're hitting the limitations of them. And I think that a lot of this and how do we overcome that, let's say, the vertical approach, etc. Those decisions lie at country level, at regional level. And that's why I'm really happy that I now hand over to Lisa for the second panel, because I think that this is a very nice bridge to the discussions that you will have. Over to you.
Right. Thank you very much, Marty. I'm Lisa Rogers. I'm working at WHO headquarters in Geneva. And most of my area and the work that I've been doing here is around micronutrients and really broadening out to anemia, where we've developed interdepartmental working groups involving those from NTDs, malaria, maternal health, and making sure that we address anemia differently. So I've really enjoyed the first panel, and thank you again from myself to all the speakers. I really learned a lot, and I think it was really powerful to hear from you. So thank you for joining us. And now I want to welcome everyone to our second panel. And as mentioned in this segment, we will learn a little bit more from the regional perspective on how we can implement comprehensive and integrated approaches to anemia reduction. So those are the approaches that bring together the nutrition, infection control, women's health, and just the broader social systems. Now, it was our intention to also make sure that we had some country perspectives as well. And we had Dr. Renee Kouami from Cote d'Ivoire, who was part of the panel, but unfortunately had to send his last minute regrets. But we do have two other panelists here that will each bring a lot of leadership experience from two different regions that have a high burden of anemia. So today with us, we have Dr. Leticia Ouedraogo Nkema. She is a team leader for nutrition and food safety at WHO's Regional Office for Africa. She supports member states to strengthen those anemia and nutrition policies, promote healthy diets, and also improve food safety systems. So welcome, Leticia. And then we also have Ms. Shahia Ali Nanak. She is the Director of Social Affairs at the South Asian Association for Regional Cooperation, and she's been overseeing cooperation across different areas such as health, education, social development, and she also has a rich diplomatic background from her time with the Maltese Foreign Service. So thank you both for being with us today as we celebrate World Anemia Awareness Day. Thank you very much. So I would like to just start us off by, we'll build on from the remarks from Luz at the opening, but also from the previous panel. And if you could just share one successful example and one challenge that you've experienced in trying to implement a comprehensive and integrated approach to reducing anemia. And if we could start with Leticia, and then we'll hand over to Shahia. Leticia, over to you.
Thank you, Lisa. I will go in French if the translation is okay. Merci beaucoup aux organisateurs de cet important webinaire. Et c'est une opportunité vraiment reconnue. Le premier panel a illustré clairement, on ne peut pas ajouter à quel point la question de l'anémie est très complexe et nécessite des actions multisectorielles. En termes de succès, le premier succès que je vais mentionner au niveau pays, c'est réellement qu'on voit de plus en plus un progrès important en termes d'intégration progressive des interventions qui ont été soulignées dans le premier panel. Des interventions également intégrées dans les plateformes de santé existantes. Et dans plusieurs pays, par exemple, la prévention et la prise en charge de l'anémie est intégrée dans les soins prénatals. Même si la couverture pose problème, on voit quand même des efforts de plus en plus d'intégration. Également, une intégration dans les programmes de lutte contre le paludisme, par exemple, pendant la grossesse, les programmes de déparasitage et également les programmes de santé qui adressent les adolescents. Un autre progrès notable ces dernières années dans la perspective de l'OMS travaillant avec les États membres, c'est qu'on a eu le développement des profils nutritionnels dans les pays. C'est un processus qui a permis d'appuyer tous les 47 États membres que l'Organisation mondiale de la santé ouvre au niveau de la région africaine, à développer des profils anémie, des profils pays en rapport avec l'anémie, où les pays ont pu mettre ensemble les données de tendance depuis 2012, analyser leurs progrès, analyser les déterminants, mettre ensemble les données pour pouvoir comprendre les déterminants et les causes réelles de l'anémie dans leur pays. Ce processus est un succès, pas parce que ça a permis de développer des documents qui vont servir plus tard, mais c'est la dynamique au niveau national que cela a permis de faire. Parce qu'au cours de ce processus, c'était une dynamique qui a permis de mettre ensemble tous les secteurs concernés. S'asseoir sur la même table, de discuter une question spécifique et de mettre les données que chacun a pour pouvoir comprendre la problématique dans son pays. Et cette dynamique, je pense que c'est un grand succès qu'il faut saluer au niveau des États membres. Donc, ce travail collectif qui a permis de développer ces profils est également utilisé actuellement pour continuer le processus afin d'appuyer les pays à développer des plans d'accélération pour la réduction du fardeau de l'anémie dans leur contexte. Un autre succès également que je peux ajouter, c'est vraiment l'attention croissante au niveau politique. Il faut le reconnaître. Et vous savez qu'au niveau continental, on a maintenant un cadre stratégique qui a été adopté par les chefs d'État l'année passée. Donc, il y a une élévation également au niveau continental. Malgré ces progrès, il y a quand même des défis. Et je vais souligner un défi majeur, c'est la mise en œuvre concrète des actions multisectorielles. C'est le grand défi majeur. Si les causes sont multiples, et connues, les programmes sont encore souvent planifiés, financés en silo. Et les systèmes d'information également ne sont pas toujours suffisamment alignés et ne permettent pas de mesurer l'impact des actions. Et de plus, les facteurs visant varient d'un pays à l'autre et à l'intérieur d'un même pays, parfois d'une zone à l'autre, également les facteurs varient. Donc, et les pays ne sont pas sur le même niveau. Et cela nécessite d'apprendre des uns des autres. Les progrès ne sont pas les mêmes dans les pays. Donc, je terminerai par des perspectives quand même. Il y a des perspectives positives. L'élévation déjà au niveau politique de la question et également en collaboration avec les partenaires et particulièrement l'Union africaine, l'OMS on va lancer une communauté des bonnes pratiques sur la question de l'anémie au niveau continental pour créer un cadre d'apprentissage, de partage d'expérience et aligné avec ce cadre mondial qui nous a permis d'avoir ce webinaire aujourd'hui. Merci, Lise.
Thank you, Leticia. And I think these are really powerful reminders that we can talk about how anemia is multi-causal all we want, but when the countries actually see their data and actually can see where the contributions are coming from and how those health areas are interlinked, then I think that becomes a much more powerful and motivating way for them to really take anemia seriously as a multi-sectoral issue and to drive progress. And just thank you for your leadership in this area. I know the countries have really appreciated this, and we are starting to see the momentum building and the progress moving in the right direction. So thank you very much for that. And over to you, Shahia. You are coming from the South Asia region, and if you could also share some of your experiences for implementing a comprehensive and integrated approach to reducing anemia, and both from the success and challenges.
Thank you, Lisa. Thank you to the organizers for the kind invitation extended to the SARC Secretariat. And Lisa, thank you so much for the very nice and kind introduction. So I think I would like to bring in a bit of a regional perspective as well to this before I go into the question. I was listening to the first panel, and Miss Geeta Lalji said something very nice, and I think Lisa, we have reiterated this on different platforms as well. And SARC definitely has done it. We're talking about donor-driven, we're talking about integration, and we're talking about supply chains. And the whole vertical system. So thank you so much, Geetaji, for highlighting that, because for SARC we have understood this, and our collaborations have very much been based on this whole system. For us, we know that reducing anemia in adolescent girls or women is central to achieving human capital development and inclusive growth across the region. We have a nutrition framework which we put together way back in 2016. Last year, in collaboration with UNICEF and WHO, we had a regional conference on reducing anemia in adolescent girls and women across South Asia. And one thing that conference really reaffirmed is that anemia in adolescent girls is not just a health issue, but a development, education, and equity challenge for South Asia. With South Asia, according to the disproportionate global burden of anemia, SAARC countries recognize the urgency of integration, evidence-driven, and inclusive approach to accelerating progress. So one thing that Colombo Conference reinforced is that anemia is not only a public health concern, but a cross-cutting social development issue, affecting education outcomes, gender equality, workforce productivity, and intergenerational poverty as well. And several countries shared their experience. And one thing we found that during the conference, the experience shared demonstrated that data-driven policy decisions can accelerate anemia reduction. And something really beautiful that came out of this conference, and something I wanted to share as a success story, is about Nepal's integrated approach to anemia reduction. So over the past decade, Nepal systematically strengthened frontline health services, combined health and nutrition programming, and prioritized equity in its anemia strategy. So as a result of this, anemia prevalence in women of reproductive age has dropped from around 41% in 2016 to 34% in 2022. And it is further projected that in 2030, this will further reduce to 27%. So that's really nice to hear. That's really nice to know that South Asia is doing so much. And these gains were equitable, showing meaningful reductions even among poor and marginalized populations. The integrated strategy included deploying community health workers to reach remote areas, linking nutrition with maternal and child health services, and using data and monitoring to guide programming. So that was really nice, and I thought that this is a very good platform to share this success story from South Asia. Of course, we do know that with all success there are challenges as well, and we know that there is uneven implementation across South Asia, and there's data limitation when it comes to anemia and nutrition. Many national programs remain fragmented, with limited coordination between health, education, food system, and social services, all sectors critical to tackling anemia across multiple causes. And this is a fact that we know and we understand. There are gaps in data quality and surveillance systems, making it difficult for policymakers to allocate resources efficiently, target high burden populations, or monitor progress over time. Even where policies exist, health systems have their own constraints, covering remote population, ensuring consistent supply of micronutrient supplements, and training frontline workers. Of course, this hinders effective scale up, but we also have to understand South Asia is a huge population when we take it globally, and there are things that each member state or each country is doing to progress or to take forward this agenda. What I also wanted to highlight here is that it's not sorry. Well, what I wanted to highlight is that, there's a need for consistent implementation. There's a need for stronger data system and cross-sector coordination, which is, of course, uneven across South Asia. But we also understand that, it is critical that there's better interministerial coordination. There's investment in frontline service delivery systems, including supply chains, workforce capacity, and monitoring mechanisms. I think I will stop here. I might have gone a little over my time, but I'll just stop here. And if there's any more questions, I'm happy to answer.
Thank you, Shadia. And I think it's such an important reminder about the inequalities. And I'm always reminded that women and adolescent girls are 3 times more likely to be anemic than men or adolescent boys. And I think it's a really important reminder that we do need to look at that data-driven approach, even within our national data systems, finding that disaggregated data to put us towards those who are most at risk within a country even. So we know that there's differences within a country, and using that powerful data to guide us to where we need to intervene the most. And I think that's a really very helpful reminder for us. I would like to pick up a little bit more on this integration. As Shia, you just mentioned, integration is possible. Progress is happening if we do that. I want to go to back to Leticia first. And because you've led substantial work on strengthening both the health information systems and strategic planning, what are some of your views on what would be the systematic changes that could enable some of these platforms that were spoken about earlier, like antenatal care, to be really a true one-stop platform where we can envision screening for anemia is happening, screening for infections, providing the oral iron containing supplements that is part of our new operational target, providing deworming, malaria prevention. How would you see that we can improve these systems so that we can serve women with all of their needs? If you have any thoughts about that type of platform, that would be really helpful.
Thank you, Lisa. De mon expérience, je pense que repenser les services autour de la vie de la femme, au lieu de penser autour de programmes distincts, cela va nécessiter des changements profonds de façon au niveau même de la gouvernance au niveau pays. Premièrement, cela suppose d'adopter une approche fondée sur le parcours de vie comme principe d'organisation des services et également des interventions en matière de santé. Et donc, cela signifie qu'il faut reconnaître les besoins de santé des adolescentes, des femmes en âge de procréer, des femmes enceintes pendant la période postpartum et la prévention de l'anémie, le parasitage, le paludisme et la supplémentation peuvent être intégrés dans ce parcours de soins-là de façon continue. Deuxièmement, c'est également l'intégration des plateformes de prestation de services des femmes, comme les services de santé des adolescents, par exemple, les soins prénatals, les soins postnatals. Donc, il faut donc harmoniser depuis les politiques et les directives et également doter des agents de santé des compétences nécessaires pour pouvoir donner ces services-là au même moment. Pas passer d'un agent de santé qui a telle compétence et un autre a la deuxième compétence, le troisième a la troisième compétence, mais donner ces paquets de compétences-là au même prestataire de sorte que, en tenant compte du cycle de vie. Troisièmement, c'est le système d'information. Le système d'information sanitaire également, il y a des choses à faire à ce niveau. Et les pays ont besoin de systèmes de données qui suivent la femme à travers son cycle de vie et non des systèmes de registre par service. Mais comment on peut réfléchir pour avoir ce système de données-là tout au long du cycle de la vie de la femme, de sorte qu'on ait des données de traçabilité sur son parcours de soins. Et enfin, tout ceci nécessite bien sûr un leadership et une gouvernance assez des pays eux-mêmes parce que ça demande beaucoup de changements et beaucoup de changements profonds et sous le leadership du gouvernement et avec l'accompagnement des différents partenaires, cela peut être possible.
Thanks, Leticia. That is so true. That leadership, the governance, and making sure that it's coming from the top, and that the recognition for the importance of addressing all these health issues within a single platform, recognizing that you don't want to overload the workforce, and making sure that you have an adequate workforce to be able to deliver these is powerful to improve the health and well-being of the women, but also to improve the learning, the economics, and all the other effects that come from an integrated approach like this. So it is possible. We've seen examples, and we need to share them, as you say. This is now about sharing and learning from other countries who have faced similar challenges. So thank you for sharing that. And then, one thing that we haven't spoken much about that we still feel is really important, and picking up of your experience from your work across health, education, and social development, have you seen any examples where combining social protection with nutrition has helped reduce anemia, or how these two factors come together synergistically?
Thank you, Lisa. Coming to your question, evidence suggests that social protection is more likely to be effective to affect nutrition outcomes when it targets the nutritionally vulnerable population, including women of reproductive health and age, and children who are the group most at risk in anemia. So when we talk about evidence, from social protection and combining nutrition and social protection together and having interventions, reviews of social assistance programs in low and middle income settings show that when these transfers, such as cash, food, vouchers, when these transfers include fortified food or are paired with nutrition support, example, behavior change, communications, supplements, referrals, women and children's hemoglobin and anemia prevalence improve more than with a transfer alone. In-kind transfers with fortified food, for example, were more likely to increase hemoglobin and reduce anemia than cash alone, right? So nutrition-sensitive social protection mechanisms that add nutrition education referrals or fortified foods onto basic transfers can bridge economic access and underlying dietary deficits, increasing consumptions of micronutrient-rich foods and uptake of health nutrition services. Now, having said that, the mechanism by which social protection supports anemia reduction should include enhanced household food access and diet diversity, behavior change communication, improving maternal knowledge of iron deficiency, supplementation, feeding practices when linked with cash or food transfers. And this comes from a very, I think this is cross-cutting across all population. Even being educated, you still lack the knowledge at some fronts. If you take me for an example, I knew about anemia. I knew the importance of taking iron-rich food, but it wasn't until I was pregnant with my first child that I realized how important it is. So these are all things that come into play. And there need to be a better engagement with health services. And if you take examples across health, social protection, nutrition across the region, if you take Bangladesh, for example, they have this school-linked nutrition programs. It's expanding school-based health and nutrition initiatives that link nutrition education, fortified meals, and health services with social services, which reaches adolescents with integrated support that address both economic and nutritional barriers. If you take Nepal, Nepal's community workers link vulnerable households to healthy and nutritional services, which includes counseling, supplementation, referrals, effectively combining community-level social support with nutrition outreach. If you take India and Pakistan, India's anemia control initiatives, including school-based iron and folic acid supplementation linked with broader social services. And Pakistan's community nutrition plus it combines with reproductive health programs illustrates how integration across sectors can support and reach and adhere to micronutrition interventions. I hope I have answered your question. I've tried to put in a lot together.
Yeah, because it is a lot. And I think you illustrate that it's not just about the intervention itself, it's about the supportive environment of which those interventions get implemented in. It's the education, it's the support, the workforce, it's the whole system around that. And so the interventions are important, but they're not sufficient alone. So I think that's really important. I understand that there is a question from the audience that Sultana Khanum has her hand up. If you can unmute somehow, or if the organizers can help unmute you and you want to ask a question live, I've been given the okay to enable that. So if you can unmute, we'd be happy to hear from a country as well. And if there's some, Sultana? Okay, if you can't, yeah, okay, yes, go ahead.
Can you, yeah.
If not, you could check it in the chat, or
Gurmeet should be able to unmute the participants so that Sultana can speak. Please do that now. Sultana Khanum.
Or maybe it was an error.
Oh, he can't. I'm sorry.
Okay, no worries, no worries. Okay, that's okay. If you want to type your question into the Q&A, then we can try and see if we can get that in the next session. But I think just wanted to really thank these two women speakers who have tremendous leadership in their regions. A few themes stood out to me today from the conversation. First, that comprehensive anemia reduction is possible. We heard some concrete examples from different regions showing that integrated approaches can work when sectors communicate, when you can align different priorities, and when you use your shared data. That's an important piece, is how can these groups come together and share data. Second, that there are challenges that remain. Coordination costs time, the systems need strengthening, and we need to be able to do better about reaching women and adolescent girls consistently, and that requires more innovation and community-driven approaches. Third, I think I want to mention that the opportunities ahead are real for us. It's not just a thought or an idea, but these are real opportunities from stronger partnerships that we've been hearing about, political commitment. We have new tools, we have new guidance, and we have some regional collaboration that is occurring right now that can really help us move forward. So thank you to the two panelists. Your reflections today really illustrate why this multi-sectoral action is not only necessary, but is achievable. We can do this, and we thank you for your leadership and your work in inspiring the global community to accelerate the progress. Thank you so much. I appreciate it. I will hand over now, I think, to Dr. Saskia Ostenthart, who is the Executive Director from the Micronutrient Forum. She's also a leading voice in advancing global nutrition and micronutrient action. She's played a central role in strengthening the evidence base and bringing partners together as well. And she'll help us guide through the audience questions and share her perspectives of what the global community can do next to accelerate action in anemia. Over to you, Saskia.
Yes, thank you so much, Lisa, and thank you also to all the speakers and panelists for giving this excellent overview on World Anemia Day, not only on why it is important that we tackle anemia, because it's actually a shame that it's still that it's still such a prevalent public health problem, while we know what will work to combat anemia. And we heard in the first panel that it's so important because it's also affecting our ability to treat and to have effective interventions for instance, for reproductive health, for malaria, and for NTDs. And I think what we heard in the second panel was really reassuring that yes, it is possible. This is not an aspirational thing. There are actual examples in countries, both in the African region as well as in the Asian region, where integration has taken place, but it will require a lot of things. It will require us to focus on data. It will require us to overcome the barriers that were mentioned, such as that programming is often done in vertical silos, and not only the programming, but also the funding. And it will require us to have data that from strong data systems that can inform in different contexts what the causes are of anemia in that context, and therefore also what important packages of integrated interventions are needed in the different contexts. We heard about the importance of national leadership and also of capacity strengthening at different levels, including at the level of community health workers and midwives. And I think I think these are important messages to bring further forward, because what we haven't really heard yet much about is that integration now is important not only for anemia but on all different levels. And with the global funding crisis that's coming up, we do see that that there is a push for more integration of nutrition interventions in the climate change agenda, in the social protection agenda, in the agriculture agenda, and also in different health agendas. And I think anemia is a prime example where that is so clearly needed, but also where we do have actual concrete evidence from countries that this is achievable and that this can work. So very encouraging, and thank you very much for all your for the panelists. Now, there are a couple of questions that were asked in the chat that kind of addresses some of the issues that were also brought up, such as, for instance, the need to illustrate not only to people working in programs, but also to funders that these integrated approaches are really needed to combat these health issues such as anemia that have such a complex that have such complex causes. And I think one question by Miriam Chang in the chat relates to this, and she's asking actually if the Anemia Action Alliance and other partners are looking into providing actual evidence about how integration could also could not only lead to more effective outcomes, but also could lead to a cost reduction, which particularly in this time and era of funding cuts is really important. So I would like to ask if there's one of the panelists that would like to address this question, and maybe since this is a question directed to the Anemia Action Alliance, and I don't want to put you on the spot, Lisa, but I do think maybe it might be a nice question for you to address. Given that this may be one of the activities that the Anemia Action Alliance could take on.
Sure. Thank you very much, Saskia, and thank you, Miriam, for the question. For the Anemia Action Alliance, we are currently working on an implementation and monitoring guide for the comprehensive framework for action to accelerate anemia reduction. And within that framework, one of those action areas is about service delivery. And we are looking at what are the integrated approaches that others have taken, and what has the impact been when they are delivered in a comprehensive way. There's been a few studies that we know of that have shown that once you have started to provide services for nutrition, for infectious disease control, for mental health, for social protection, once you provide all those together, the impacts are so much greater. And so we are doing a review to look at all those different examples and putting them into our implementation guide. So there are some activities happening in that area, and we hope to be pilot testing this comprehensive guide in the summer, late summer. So if you are interested, please don't hesitate to reach out to us, the Anemia Action Alliance or myself, and we'd be happy to share that with you. And if any other experiences out there, we're collecting those now. So thank you very much for the question. It's an important one.
Yes, thank you, Lisa. And yes, this is also a call to go to the Anemia Action Alliance site, because the Alliance is really actively working with countries to help them in these integrated approaches to combat anemia. There's also been a lot of speakers that emphasize the need for a data-driven approach, and that is important also because the context specificity of anemia and the need to have data available that can help to understand the causes of anemia in different contexts, and also can help to understand what type of packages of integrated interventions might work best in a particular setting. Now, this is of course again a challenge, particularly in a time when funding cuts are threatening data systems, and where data systems need to continue to be strengthened. But it's a very critical point that came out also from this from this intervention. I would like to ask Marty if you could briefly address this question, particularly since there was the question that Kendra Siegmans asked, which was, are there any examples of how data can be analyzed and used to show the need for integration? And I want to specifically ask you if you could refer back to a workshop that the Anemia Action Alliance actually held on the use of data to identify the causes and the interventions for anemia. So over to you, Marty.
Thank you, Saskia. And actually, that's a good question. I hope my memory doesn't serve me wrong. But yes, in I think 2024, we co-organized again with the Anemia Action Alliance a meeting on what data, a meeting where we brought, I think, about 100 people together from about 13 countries to really look at what data do we need to, at a national level, really assess the anemia situation, what are the drivers, etc. And so there were a couple of tools that were discussed in that meeting. But one of the tools that many here may know is a tool that was developed by the Spring program of USAID, and that was called, I think, I can hear you, a district or national assessment landscape or so of anemia data. And the intent at that time was to adapt that tool, which exists already for many years, to the new WHO comprehensive framework. But unfortunately, again, that would be funded by USAID. And yeah, we all know what happened there. So I think there's still an opportunity to people to do that. And Saskia, in the meantime, posted the link to that meeting. So we didn't only talk about the Spring tool, but we discussed many other things. Maybe this answers Kendra's question. Over, back to you.
Yes, thank you, Marty. I would like to end this webinar with a thought that was also expressed by one of the panelists, and that is that integration does not happen by itself. It really requires intentionality, but it is important to address a public health problem that's not just a public health problem, but also a social development problem that is so complex, as is the case with anemia. It is also important, as I said earlier, in this time when funding cuts will force us to work more effectively and more efficiently with reduced resources. And I think we've seen in this webinar that it's possible, and that there are examples already in countries where this is happening, but it will require leadership. And I would like to ask if the slides can be put up, because I would like to tell you that this is also an important topic that will be discussed at the Micronutrient Forum 7th Global Conference, which will take place this year in September in Accra, Ghana, and which has as a theme nutrition at the frontiers of a changing environment. And this changing environment means that climate change, that conflicts that population displacements, but also funding cuts are threatening the progress that we can make in addressing nutrition and public health. And integration of interventions is one important topic and priority theme that has been identified by the program committee. And it's also an area that's been pushed a lot also by the donor community with the launch of the Nutrition Integration Compact that happened last year at the Nutrition for Growth Summit in Paris. What we want to do at the conference is to evaluate the evidence on where did integration work. And again, anemia is of course a prime example because I think the recognition that anemia is not just a nutrition problem, but it's also a malaria problem, it's a reproductive health problem, it's a gender problem, it is a NTD problem. I think that recognition has already been landed in the community, and we have more examples and more evidence from countries and regions, what works and what doesn't work, and what is needed to remove existing barriers for us to move to these integrated programs. So I want to welcome you all to attend the Micronutrient Forum Conference and learn more about this topic in September in Ghana. And finally, what was said is that some of these topics have also been addressed in a series of policy briefs from the Anemia Action Alliance and the Micronutrient Forum that will be published very soon, and we will share the links to these policy briefs with all the participants in this webinar so that you can review them, and we would welcome your comments, and also if you have additional examples of interventions or of integrated interventions that worked, please share them with us. So with this, I would like to end the webinar. I would like to thank again all the panelists for sharing their experiences. I would like to thank the speakers and the two excellent moderators, Lisa Rogers and Marty van Lieren. And I would like to welcome you to visit the website and learn more about the Anemia Action Alliance and consider joining the Alliance. And thank you very much and have a very nice day.
Thank you, Saskia.
Thank you, everybody, and have a nice day without anemia. And next time.
Yeah, thank you, Marty. We appreciate all the support.
Bye.